Okay,
Hello.
the next speaker is Ricardo Casal. Ricardo, do you hear me?
Good morning, everybody.
Good morning. Good morning.
Do you hear me?
Yes, yes,
Okay. Now? Now it's good?
yes. Everything is okay.
Okay. Thank you very much. Sorry for this. I'm very thankful for this invitation. It's an honor for me to be there with you here online. I'm Dr. Casal from Madrid, endoscopic spine surgeon since 13 years ago. I want to begin here. It's the truth that it's easy to make things complicated, but it's hard to make things simple. And in order of this, I wanted to bring this scheme, which is what I have on my mind when I head to a patient and think about what we can do with him. And these are all our endoscopic options nowadays. There's a lot of them, transforaminal, interlaminar, a few endoscopic fusion options. And we're here today to talk about our endoscopic lateral axis. This is our journey in the endoscopic fusion. We began in 2015 with the Endo-LLIF, going through the transforaminal or transcambing or through the foramen with the cages. And we developed our trans-SAP on 2017 to solve all the L5S1 problems. And in 2019, we began to do Endo-LLIF, which is a little bit more simple with the expandable cages, and also this new lateral approach that we're going to talk about today, the Endo-XLIF or endoscopic lateral lumbar interbody fusion. This approach, we began to do it doing mixture of open and endoscopic technique, trying to introduce the endoscopy in the traditional open XLIF technique. We began to do finally 4 cases on the lateral position, completely endoscopic and percutaneous, and until today we did 82 cases that we have been performing in the prone position. We are already doing in the prone position all the cases. Now, this is the paper that we delivered last year in 2023, presenting the technical note and first cases. And I brought this first case, which is a severe back pain with mild neurogenic claudication. And we decided to go lateral with endoscopic approach, preparing the disc space, as you can see there in the image. We do 2 axes, one of them to take bone graft from the iliac crest, which is one of the great advantages of this approach. This is a nice video in which you can see the vision of the disc space, how we work on it. On the lateral position, you can see the end plates perfectly preparated and to receive the cage. That's the bone graft to introduce inside the interbody space. You can see there. And after that, the introduction of the cage and the transpedicular screws and the final image of our lateral interbody fusion. It's a nice picture with nice lordosis. Maybe it's a small cage if you're thinking about the traditional XLIF, which is based in large cases from side to side. We're working on it. You're going to see it now. This is the clinical results. The patient is really happy a few hours after the surgery. This is 1 week after. and he's really happy with the results. It's really amazing. This is a second cage, 2-level with a herniation. This shows us how we can go lateral in 2 levels through same incision also, and also using the same incision or another one, transforaminal, to go through the herniation, as you can see there in the image. And the clinical results 12 hours after the surgery, the girl is very happy. And as you can see, the pain is quite well controlled. Okay, now the future is going to give us a lot of uses and advantages with this approach, I think. One of them is to work on the anterior ligament. We can work easily on it, much easier than go pre-psoas on the open technique. We can cut it and improve the lordosis. There's options to take the bone graft very easy through the same incision. And one important thing is that we can go transiliac. Transiliac is a great advantage because when we do open XLIF with the high iliac crest, we have a real problem. And in this option, it makes it even easier because the tunnel on the iliac crest, it's like a tripod. It's like if you're much stable, so it's very nice to work on it. So there's a lot of options, and we tried to do screwed cages, but I think the materials are to develop, and this was really difficult. I don't think it's reproducible nowadays. Probably in not many years we're going to be doing this, and this is what we are doing. This is our latest case in which we have already begun to use boxes, cages, similar than those of the original technique, thus achieving better support on the cortical of both corticals of the vertebral body. So this is quite as doing the original technique with very big cages, as you can see, with lordoses. And okay, so now in the paper we talk about few advantages that probably in the future are interesting. This approach maybe lets us put the cages, but also work on the anterior ligament, work on herniations from inside out, from the contralateral foramen, from the central canal. It's easy to reach from the lateral. Maybe do biopsies or work on psoas, hematomas, or abscesses. And of course, the technique, I think it's very interesting in combination to solve complicated cases in which you have to go lateral, but also go transforaminal or interlaminar, or maybe combinations of cages, as we're gonna see now. Now, advantages of the technique: it's very reproducible. The surgical time is very short. It's quick. There's no bleeding, almost no bleeding. The neurological, very safety, much more than open XLIF. We always operate with neurophysiologist on the surgery room, and the neurophysiologist doesn't see us, almost doesn't see us. And we didn't have neurological events. It's very compatible with other surgical acts, maybe endoscopy in the same level or different level, or other techniques in other levels and with the percutaneous instrumentation. And I think it's a promising option to amplify the endoscopic options and solutions. Of course, talk about the drawbacks. it needs to be an expert with the endoscope, both for the technique itself and for the endoscopic gestures that may accompany it. And of course, viscera or blood vessels, I think there's very low risk, but always have to keep in mind in order to prevent. I think this is mandatory. And specific material is to come to improve and make even safer and more reproducible. We are already working on this new material to make this even easier. And heading to an algorithm for the endoscopic fusion on the lumbar spine, mainly because nowadays we are not thinking about anything different. We not even think about doing any open fusion, only in very, very complex cases. And of course, the planification is very important. The study of the MRI, preparation of the case, checking when and where, and the way we're going to get in to the interbody, and what we're going to find in the way. And this is important not only for the lateral approach. This is important to planify all the complex cases with all kinds of fusions. So we're going to go to an algorithm that tells us how to head to cases like this, for example. Maybe we have to decide if we go lateral, if we go transforaminal, if we go endoscopic PLIF from posterior, and choose which is the best option to combine one cage, other cage, one approach, other approach, to solve cases complex like this. And this is, for example, our option in this case: 3 endo XLIF cages, 3 lateral, and 1 endo PLIF to solve a 4-level problems, or maybe this one for 3-level problems with 2 cages endo XLIF and 1 endo trans SAP for the L5S1. Or this one, for example, 2 lateral cages and 1 endo PLIF with expandable cage on the L5S1. So we're going to go to an algorithm to decide which is the best approach for each level in each patient. And well, remember, they're only experts indications, so beginning with the endoscopy, maybe it's not the best idea to get to this directly, but it is on the possibilities of endoscopy. I want to introduce you our Spanish society, and remember that all of you are very welcome with us here in Spain whenever you want. And thank to my team, and best regards.
Thank you very much, dear Ricardo. A really nice presentation, very interesting. Would you like visit Zurich in October? In Smith?
That would be great.
Welcome to Smith, and maybe we will see each other in October in Zurich. Thank you very much.
Thank you very much to all of you.
Thank you. Bye.
Bye-bye.